This activity, titled Guidelines of Addressing Obstructive Sleep Apnea in Pregnancy During Women's Health Month, is hosted by Carolyn D'Ambrosio. Dr. Carolyn M. D'Ambrosio is a professor of medicine, associate vice chair for education, and director of pulmonary medicine in the section of pulmonary critical care and sleep medicine at the University of Miami Miller School of Medicine. She previously held leadership roles at Yale University School of Medicine and Harvard Medical School, including serving as program director for the Harvard Brigham and Women's Hospital Fellowship in Pulmonary and Critical Care Medicine. A nationally recognized expert in pulmonary critical care and sleep medicine, she has contributed extensively to medical education as chair of the American College of Chest Physicians Sleep Medicine Board Review Course, associate editor for Chest Pulmonary, and editorial board for the SEEK Self-Assessment Program. Dr. D'Ambrosio has received numerous honors for teaching and leadership, including the Distinguished Teaching Award at Tufts Medical Center, the Pillar Award for Educational Program Leadership as Mass General Brigham, Outstanding Educator at Yale, and the 2023 Outstanding Program Director and Medical Educator of the Year Award from the Association of Pulmonary and Critical Care Medicine Program Directors. She is also a recipient of multiple CHEST awards, including Distinguished Educator, Distinguished Service, and the College Medalist Award, and serves on the Chest Philanthropy Board of Trustees. Her scholarly work focuses on sex and gender differences in lung disease, with research spanning sleep and menopause, infant breathing, and related topics, and she is co-author of Comfort the Kid, a book on infant sleep and parent bonding. This activity is from the American College of Chest Physicians. Here is your host, Dr. D'Ambrosio.
Welcome to today's episode, where we will focus on an important and evolving area in maternal health: the identification and management of obstructive sleep apnea in pregnancy. Pregnancy is a uniquely complex physiologic state with cardiovascular and metabolic changes that can both increase the risk of OSA, obstructive sleep apnea, and amplify its potential impact. Unlike the general population, the timeline from exposure to outcome is compressed, and what occurs during pregnancy may offer critical insight into both immediate and long-term health risks for both the mother and baby. Despite this, clinicians have often had to extrapolate from non-pregnant populations, highlighting the need for clear pregnancy-specific guidance. In this session, we will review new guideline recommendations developed by a multidisciplinary panel of experts across sleep medicine, pulmonary care, obstetrics, anesthesia, endocrinology, and nursing. These guidelines aim to provide practical, evidence-informed direction on who to screen, and how to safely and effectively treat OSA in pregnancy. We'll also discuss real-world implementation, how providers can integrate screening and treatment into the limited time frame of prenatal care, improve patient counseling, and navigate challenges unique to this population. Ultimately, our goal is to increase awareness, support clinicians in delivering equitable, high-quality care, and improve outcomes for pregnant patients and their children. Let's get started. I'm your host, Carolyn D'Ambrosio, and I would like to welcome my guest, Ghada Bourjeily. Dr. Bourjeily is a professor of medicine at the Warren Alpert School at Brown University and professor of health services, policy, and practice at the School of Public Health at Brown University. She has been studying sleep and pregnancy for more than a decade and has published extensively on the topic. Her research has been funded by the National Institutes of Health, and she has received many foundation awards, including the Chest Foundation and American Academy of Sleep Medicine Foundation. She has co-chaired the guideline with me, and we are looking forward to seeing the document in print very soon. Dr. Bourjeily, thank you for being here today.
Thank you, Carolyn, for having me. I'm glad to be here.
So, as you know, you and I had many discussions about this. It is a difficult sticking point in treating pregnant patients that we didn't have clear, massively huge studies to guide our care of these patients. So I think that was one of the things that prompted it. But give me your impression of why you think a guideline is needed for OSA in pregnancy.
So as you said earlier, Carolyn, I think the pregnant population is unique in a lot of ways. And there's a lot that is difficult to extrapolate from the general population because it simply does not apply. So as you mentioned, the pregnant period has a lot of physiologic changes that may be relatively short-lived, but still they may carry a risk for obstructive sleep apnea and then increase the risk of women developing sleep apnea during the course of pregnancy or having a worse sleep apnea in general, so worsening of the disease itself. And you also mentioned that the time from exposure to an outcome is also contracted in pregnancy. So when we look at incident outcomes that develop in patients that have obstructive sleep apnea outside of pregnancy, we need to monitor them for years after we make the diagnosis of sleep apnea in order to see whether any of these outcomes is going to develop. In pregnancy, the whole event of pregnancy is 9 months or so. So from the time that we make the diagnosis of sleep apnea to the time that some of these cardiovascular and metabolic outcomes occur in pregnancy is pretty short, which is an advantage in terms of making a difference in monitoring interventions. But it's also important because these outcomes impact the health of the pregnancy and the health of the baby. And you also mentioned that there are some long-term outcomes that are associated with some of these pregnancy-specific outcomes that are associated with OSA, like gestational diabetes and preeclampsia. Those have been linked to long-term cardiovascular and metabolic health. And because sleep apnea is quite common in pregnancy, even in average risk or low risk individuals, and obviously much more common in women that have either obesity or diabetes or hypertension, it makes it even more convincing that we need to examine outcomes and know what to do with these patients and how to manage them in clinic when they come to be seen. And in addition to that, the use of treatment in this population and implementing treatment and diagnosis and management may carry some specific challenges in this population for many reasons. They have trouble with access sometimes. They may need more frequent OB care than we're used to in the non-pregnant populations. They have some specific nocturnal symptoms that may also impact their sleep, but also impact how they use treatment for their sleep disorders while they're sleeping. So having guidance from experts is really important, especially because the field is relatively new and we don't have a lot of data. So we needed some expert consensus until we have more solid data that can guide us in the future.
So the work's been done. We're going to get this published very quickly. How do you see these guidelines impacting clinical care of pregnant patients?
So the guidelines were developed in a way that would be directly relevant to clinical care. So we utilized some very specific methodology for the guidelines, and we believe that it provides an overview of all the existing evidence in the literature, as well as the opinion of a panel of experts in sleep disordered breathing in pregnancy. And these guidelines will help clinicians make decisions on who to screen in pregnancy, how to screen them, how to treat them, like what kind of therapy to use, and what is known to be effective and acceptable and safe in pregnancy, and what is not. What do we need to try to stay away from if we can, and how do we modify these decisions to fit within clinical care?
Yeah, you touched on this a little bit, but how do you envision providers actually doing it, implementing these recommendations?
So this is a complicated question in general. Yeah. I'm hoping that providers will be more comfortable screening and treating pregnant women in pregnancy and counseling them on the risk of benefit of screening and benefit of therapy itself as well. And we're hoping that it will increase awareness of the problem and its prevalence and impact so that we can make a difference in improving maternal health. But this is a complicated issue, as I mentioned, because the care of pregnant women is mainly provided by the obstetric team. And then there are some consultants that might see patients during pregnancy, but not see them on a regular basis. So trying to implement screening for some important sleep disorders like sleep apnea, and if women screen positive, making sure that there is a path that is clear towards testing for sleep apnea to make the diagnosis. And then once the diagnosis is made, having, again, another pathway that provides timely interventions when interventions are needed. So I think we need to make a conscious effort to have sleep teams and pulmonary teams work closely with the OBs so that when the OBs are screening for these disorders, the women are not getting stuck in a bottleneck of, okay, they tested or they screened positive for OSA because they're snoring on a regular basis, they have a suggestive phenotype, that now I need to wait 3 months to diagnose them. So we need to work among teams and among multiple disciplines in order to make sure that this gets done. And the guideline itself isn't going to create these pathways, but we're hoping that by increasing the awareness about these guidelines and about the disorder, that teams are going to want to work together to make the care of pregnant women more seamless and more streamlined.
Great. I think that you're absolutely right. The team approach, particularly in pregnancy, is actually already used, right? We often have patients who are pregnant who see other specialists and they work together. For this particular guideline, what do you think is the most important takeaway from these recommendations or takeaways from these recommendations?
One of our big accomplishments, before I talk about the takeaways, had been having this multidisciplinary team of specialists where we invited input from sleep docs and sleep scientists and pulmonologists and high-risk obstetricians, OB anesthesia, endocrinology, nursing from around the US and some parts of the world as well. So we were trying to invite opinions and thoughts from people as sleep apnea in pregnancy impacts their specialty or the things that they are going to do specifically. So that way, I believe we have been able to get this multifaceted view of the problem, which I think adds to the value of these guidelines. And some of the key takeaways that I think are important for our audience to be aware of are that we need to screen pregnant patients better. We don't do a very good job even now screening them for sleep apnea. So looking for any symptoms of sleep disordered breathing and screening for sleep apnea. And especially those that have some specific risk factors that increase the risk for sleep apnea. So women that have an elevated BMI, or those that have a history of gestational diabetes or chronic hypertension or a history of preeclampsia, we know that there is a strong association between sleep apnea and many of these disorders. So that increases the risk of these women having sleep apnea as well. So this was one of our main takeaways as well. And then we discussed at length like how we would treat women that have sleep apnea and thought that the treatment with positive airway pressure, so, CPAP, but mainly auto-titrating PAP, makes the most sense in this population. So we use auto-titrating modes because the physiologic changes of pregnancy may actually impact upper airway resistance as pregnancy progresses, with weight gain and the diaphragm becoming more elevated, FRC reducing, and some swelling around the upper airway as well, for various reasons. So auto-titrating modes can allow us to accommodate for the increase in airway resistance and the need for higher pressures as well. And then we also have considered alternative therapies, and we provided some recommendations based on the existing evidence. This was a little bit harder because there's not a lot of evidence, and we definitely need to examine alternative therapy, especially that now we have many options in the general population about how to treat individuals that have obstructive sleep apnea. So there's a lot that needs to be done in there. But for now, we recommend that positive airway pressure should be the first line therapy in these patients unless they don't tolerate them. We also have discussed what to do with individuals that are treated but still have some residual sleepiness that goes beyond pregnancy physiology. So that's a little nuanced here as well, because there are some symptoms that are intrinsic to pregnancy where women feel tired and they might feel, excessively sleepy, and their sleep habits might change and they take naps, more often than non-pregnant individuals. But at any rate, so we discussed what to do with this residual sleepiness, and we reviewed a lot of the safety data and the efficacy data whenever there were any efficacy data that were available. And we thought that for patients that have the ability to take naps in the daytime when they're feeling sleepy, that they should resort to that first before taking any stimulants. But we provided some careful guidance and counseling regarding the use of stimulants, especially because there are patients who may not have the ability to take naps during the day because they work full time and their job doesn't allow it and they don't have a place to go and relax and take a short nap. And one of the other key messages that we also discussed is the fact that we need to think about how to monitor patients, because pregnancy is a dynamic state where some things that may be true and relevant in early pregnancy may be less true as pregnancy progresses. And some things that may look benign earlier in pregnancy may progress and become more severe as pregnancy progresses. And we also discussed the applicability of the recommendations that we're providing to various populations. So are we adding to inequities in making these recommendations, or are we potentially improving inequities by making specific recommendations? And we tried to keep a global mindset as we thought about a lot of these recommendations, because what is available in one country may not be available in other countries. So we did our best to make these recommendations, specific where they needed to be specific. And we wanted to make sure that we could enhance equitable care if we were able to.
Well, with that, I would like to thank my guest, Dr. Ghada Bourjeily, for speaking with me today, and of course, our audience.
Thank you very much for having me, Carolyn. It was a pleasure to work on these guidelines, and I can't wait to see them in print, hopefully sometime soon.
I agree. Thank you, everyone.
Thank you for joining us and listening to Guidelines of Addressing Obstructive Sleep Apnea in Pregnancy During Women's Health Month. This is a non-promotional, non-CME disease state educational program brought to you by CHEST.